between scar and recurrence, but also to immunomonitor our therapies and to be more specific in our therapies. There will be no specific antigen, I guess so, for the future, but there will be maybe a panel of different antigens, and we can, for example, spot these antigens on a biochip and be more successful in our diagnostic procedures. But the sole one specific antigen, I guess we won't see it in the next, 10 years, 15 years or so on. And we have...
And the problem that the tumor has evolved despite immunological surveillance.
Yes.
The tumor is known to the immune system.
Yes.
Is this a major drawback? For example, if you take now HPV immunization, it will probably work in cervix cancer, but will it work in an adjuvant setting in head and neck cancer patients?
Nobody knows, because normally these patients are heavy smokers, they have a severe alcohol intake, and that also can impair the immune system, as we all know, and this maybe also impairs the vaccination procedures. Another issue are the molecular margins. Normally we just resect the tumor and we send it to our pathology department, they do an HE staining, and that's it. But we don't know what's going on at the borderline clear to the healthy mucosa. So we also have just to imply new methods in discriminating between healthy or so-called healthy mucosa, which is, we all know, the condemned mucosa. So there are different approaches implying molecular biology, but therapy alone is only one thing. Diagnostics, immunomonitoring is also a very big issue we just should focus on.
Dr. Singh?
Coming back to the issue of the papilloma vaccine, it is not a therapeutic vaccine. It's not marketed as a therapeutic vaccine, either in cervix cancer or then therefore in head and neck cancer. It is a preventative vaccine, and that prevention may be different based on the anatomic location of the tumor, because we don't know when the papilloma infection is encountered within the head and neck region, as opposed to definitive sexual activity leading to infection in the cervix.
I was making this point because, for example, in immunotherapy, we have the phenomenon of immunoselection, of epitope loss, variants of the tumor, which then overgrow the original tumor population. And you pointed out in your talk that we also have a resistance problem, which we didn't realize in the beginning of this whole story, in targeted therapy. So we end up in the same situation like we do with classical chemotherapy. There we as well have the great problem of development of primary and secondary resistance. So do you see any particular differences which may make it more easier to circumvent resistance in targeted therapy or in immunotherapy or in classical chemotherapy? Or will we have always the same problem because of this heterogeneous tumor genotype which always evolves and escapes and makes fuzz and fizz?
I think we have to realize that every single kinase targeted therapy, whether it be for GIST or for EGFR, over time a resistance develops in the tumors. The mechanisms of resistance overlap. So if the way that the first mutation that was found in EGFR, for example, the way that it was screened for was based on looking at where the mutations occurred in the other kinases in which there's targeted therapy. These are highly adaptable tumors, and they will become resistant over time. That's why they grew, and that's why they survived all of the screening methods that are present within our own protective system. They will become resistant, and the reality is the best that we can hope to do is really make it a chronic disease, which we have a lot of examples of: diabetes, heart disease, and the list goes on, so long as longevity is not compromised and quality of life is maintained. If it is a chronic disease, it makes no difference.
If I may add, and I fully agree to Dr. Singh, what I would like to add, and this is particularly true for immunotherapy, is the effect we also have to apply this in an appropriate setting. And this means, most likely, at least if you do it in a therapeutic setting, you would like to use it in minimal residual disease. So what is often the limiting factor in a cancer is that we consider this as one cancer. And we say there are, let's say, if we can detect it, it's at least 1 billion of cells already. but these are basically probably at least 1,000 or 1 million of different tumor cells because of the genetic instability of them. And what we then often simply do is not really that we drive the occurrence of a new mutation under therapy, but we favor the outgrowth of one of these many clones that is there, that so far had a hard time to compete with the other ones, but now, since the other ones are sensitive to therapy, they're taking out now this individual tumor cell. Now all of a sudden there's the freedom to grow and proliferate, and then it will present a couple of years later then. And therefore it is important then, for example, in immunotherapy, to dramatically decrease this, the number of cells, so that you decrease the chance of the tumor to escape. And if you then come from different angles, and ideally there would be an immunotherapeutic approach, and then let's say a kinase or oncogenic pathway approach, for which there is little probability, if any, that there is one mutation sufficient to take out both treatment approaches, then I think you can be effective. And the point is the immune escape of the tumors that's typically being mentioned. This is most likely or most often due to the fact that indeed the tumor by its mass now has found ways secreting immune suppressive factors, or it has lost maybe one epitope. But that doesn't mean that the tumor itself is no longer amenable to immunological or other therapy. We just have to debulk it, have relieved the suppression, and I think there is right now one agent or several agents in the clinic, so take things like the CTLA-4 antibodies, which kind of just take away the brakes from the immune system. And then you can see you get dramatic responses all of a sudden against the tumor. The limitation of that is, right now we have to so primitively take away the brakes of the immune system that we get autoreactivity. And basically this treatment is just as bad as a really bad immunotherapy, like a transplantation. And we have to work on that, but it has clearly been shown you can be effective also with immunotherapy. But again, you have to do it in the right setting.
Dr. Strepart, do you think that the characterization of stem cells will help to avoid these problems of resistance, so that there we have not only that we can define specific targets in this, well, supposedly very important progenitor cell?
Well, I think the first step is that we have to identify the stem cells first, and for different types of tumors, and do the characterization on these stem cells. I think here we are in a very early phase of the analysis, and it's still pretty early to speculate whether targeting stem cells or treatment of stem cells will help us to solve the problem.
Mm-hmm. You agree?
Well, I think the big question is, are stem cells the origins of these tumors, or do differentiated cells de-differentiate and resemble stem cells? And that's a harder question to answer. I think the field right now is definitely going in the direction of suggesting that many of these tumors start as stem cells and then they differentiate. But there's a lot of examples, such as in thyroid cancer, where it may occur in the reverse direction. Depending on which pathway is involved, I think it will impact on the therapeutic benefits. A de-differentiated cell is not going to be a progenitor. It is the endpoint of the process, and therefore may not be a great target. And so I think there's a lot more research required before we think that a targeted stem cell therapy will be the ideal therapy.
Unfortunately, I think we will have to stop now our discussion, because we don't want to be the next session to start late. Final comment, final statement. I think most statements have already been given. We have to see the individual patient with his individual tumor. We have to collect data. We have to be able to get back on tumors which we have treated some time ago, and then we can have a look why it responded like in this or that way. We will have to use multi-targets, multi-therapy approaches to multi-targets. We will have to be optimistic, but not euphoric, probably. And I think this panel showed you very clearly that this is a very interesting field of research, but it's not so easy, and don't believe what you read in the papers. What helps in the mouse model not necessarily helps in our model. And thank you very much for being here so early in the morning. And thank you to the panelists. Please.
I would like, if I may be allowed, to make one provocative statement to the audience, because that's what I understood is being asked explicitly. I would like to make you thinking about also changing your approach. So this is a meeting here today designed for head and neck cancer. And typically when we design in clinical trials and think also about applications of drugs, we think in organic indications. So I could imagine, or I would like to stimulate the provocative idea that in a couple of years we will have such a meeting, not on clinical findings on head and neck cancer, but we will have a symposium on clinical findings related to EGFR receptor therapies, to PI3 kinase therapies, to estrogen receptor therapies, where colleagues from different fields come together and discuss it, because much of this discussion that's typically been taken saying the indication gets too small because we stratify subgroups, in my opinion, isn't really true. Just the spectrum will shift. There will no longer be head and neck cancer as such, but there will be 30% of head and neck cancers and 20% of lung cancer and 15% of colon cancer, making the patient number for a given drug just as big as it is right now. But we have to also adapt, like the tumor does, to the challenges with regard to clinical development and application. Just as a provocative idea.
Dr. Streper, something to add?
Well, my take-home message would be that we thought of kinase inhibitors as very specific inhibitors that target a single kinase. I think we have to change our paradigm in the future to multi-targeted kinase inhibitors like the raffinib or sunitinib. I think we have to give these types of inhibitors which target different pathways. We have to test these inhibitors and give them a chance to show what kind of potential they have. So my best bet would be that instead of targeting single transduction pathways, we have to change our view or change the paradigm to multi-targeted kinase inhibitors and see what kind of potential and what kind of success they will have first at the bench in preclinical settings. And I think we have to do our homework first. As coming back to your question, how can we cut the costs? I think we have to do the preclinical work first very thoroughly, and then we have to turn to the clinic, and that's one way of being more successful, have lower attrition rates, and save costs.
Dr. Lang?
Well, we are here in Frankfurt, and the economists would say, what goes up must come down. And we have seen that for gene therapy, for adoptive immunotherapy, but hopefully for molecular target therapy, we are more successful in the future.
Dr. Singh?
I think, remember every drug that was shown on here, because 5 years or 10 years from now, none of them will probably be used in the treatment of head and neck or probably any other tumor. I think what we have to realize is we're really at the beginnings of biologic-based therapy, and a lot is yet to come. The technology is advancing, our ability to identify new agents is advancing, and the combination will change our field over the next 10 years.
Thank you very much. Thank you.